Hello, and thank you for joining today's webinar, Navigating Moral Distress and Online Harassment of Healthcare Workers in Canada. This will be the first of many webinars in our new webinar series in collaboration with the Bridge Research Consortium, so we're excited to have you with us for this important discussion. I'm Antonella Pucci, the Manager of Immunization Initiatives at the Canadian Public Health Association, CPHA, which is Canada's independent national voice for public health. And I'm responsible for managing Immunize Canada, a national coalition housed within CPHA dedicated to promoting the benefits of immunization. I'll be the moderator for today's webinar, and on behalf of CPHA and Immunize Canada, it's my pleasure to welcome you and to host this session. Next slide, please. For this webinar, we would like to respectfully acknowledge that our CPHA and BRC team members work and live across Canada on the unceded territories of the First Nations, Métis, and Inuit people. I myself am based on the unceded territory of the Algonquin Anishinaabe, and our presenters, Dr. Smith, Dr. Torek, and Dr. Tanov, are primarily based on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. Next slide, please. Now, on to some housekeeping. This webinar is being recorded on Zoom. A recording of this webinar will be made available on immunize.ca and Immunize Canada's YouTube channel shortly after. If you have any questions regarding technical difficulties, please contact immunize@cpha.ca and we'll reply to you as soon as we can. If multiple people are experiencing the same problem, we'll address it live via a broadcast message in the chat. As for the questions and answers session, you are welcome to submit or upvote questions for the speakers in the Q&A tab at any point during this webinar, and they will be answered at the end of this presentation. However, due to time limitations, not all questions can be answered. Finally, we would love to hear your feedback, so please fill out our 5-minute short evaluation survey upon exiting the Zoom platform. We'll also be sending it via email. Next slide, please. So before we jump into today's webinar, we'd like to tell you a little bit about the Bridge Research Consortium and how their partnership with us at CPHA came to fruition. So the Bridge Research Consortium, or the BRC for short, is a project within Canada's Immunoengineering and Biomanufacturing Hub, led by the University of British Columbia. And it is one of 19 projects funded by the federal government through the Canada Biomedical Research Fund to support Canada's life sciences strategy, aimed at rebuilding a strong and resilient domestic biomanufacturing and life sciences sector ahead of a future pandemic event. So you see, Canada's work developing new vaccines and immunotherapies holds real promise, with the potential to create innovative vaccines and therapeutics that can save lives and improve health. But one key challenge remains: achieving public trust and optimal uptake of these advancements. The COVID-19 pandemic highlighted that scientific innovations alone aren't enough. Success depends on whether people can and want to use these innovations. Hence, building public trust and equitable access is just as critical as advancing the science behind developing new vaccines and immunotherapies. Therefore, integrating social sciences and humanities into the therapeutic pipeline and immunization system can contribute to addressing this challenge. And that is exactly where the Bridge Research Consortium fits in. This multidisciplinary team of leading social scientists and humanities scholars, along with public health and biomedical experts from across Canada and beyond, bring together, or rather bridge, wide-ranging expertise and perspectives to better understand and support public trust and equitable access to new vaccines and immune-based innovations that strengthen Canada's readiness for future public health emergencies. Through interdisciplinary research, training, and knowledge mobilization activities, the Bridge Research Consortium's approach focuses on proactively understanding evolving challenges, meaningfully engaging with diverse knowledge users and priority populations, and finally, creating innovative trust-building initiatives. Next slide, please. So the Canadian Public Health Associations, the Canadian Public Health Association through Immunize Canada will partner with the BRC to share opportunities for public health communities to inform ongoing research, co-create knowledge mobilization outputs that support the implementation of evidence-based practices, launch a quarterly webinar series to explore emerging immunization topics like today, and participate in other activities, which include, but are not limited to, hosting future workshops and training sessions, and developing a guide for healthcare workers aimed at demystifying the different stages of the therapeutic pipeline. Next slide, please. So today's webinar will discuss the following objectives: explore the experiences and impacts of moral distress and online harassment on healthcare professionals in Canada from the COVID-19 pandemic to present, identify strategies to reduce and prevent online abuse and harassment, and contribute to the ongoing efforts aimed at supporting healthcare workers to navigate moral distress and online harassment amid rising vaccine hesitancy. So with that, I'm delighted to introduce to you our three speakers, Dr. Julia Smith, Dr. Heidi Torek, and Dr. Chris Tanove. Next slide, please. Firstly, Dr. Julia Smith is an interdisciplinary social scientist aimed in policy analysis and political economy with a focus on gender and health inequities. She has over 15 years of experience working with health and development programs in Canada, Europe, and Africa, and frequently works in consultation with government and civil society at both the local and global level. Her research has been funded by the Bill and Melinda Gates Foundation, the Canadian Institutes for Health Research, the Social Sciences and Humanities Research Council of Canada, and the U.S. National Institutes of Health, among others. She has authored dozens of peer-reviewed articles, chapters, and reports, as well as a book titled Civil Society and the Global Response to HIV/AIDS. She is a faculty member at the Center for Gender and Sexual Health Equity and alumni of the Rotary Peace Fellowship. As for Dr. Heidi Torek, she is a Canada Research Chair and Professor of International History and Public Policy at UBC. She directs the Center for the Study of Democratic Institutions. Her work examines history and policy around communications, particularly the effects of new media technologies on democracy and health communications. She is a senior fellow at the Center for International Governance Innovation, as well as a non-resident fellow at the German Marshall Fund of the United States and the Canadian Global Affairs Institute. Along with writing policy reports on topics including COVID-19 communications and online harassment, Heidi has briefed and advised officials and policymakers from governments around the world on media, democracy, and the digital economy. Her writings have been published and featured in major magazines and newspapers, including the New York Times, the Foreign Affairs, the Washington Post, the Atlantic, Politico, the Globe and Mail, the Financial Times, CNN, and many others. And finally, Dr. Chris Tanove is a research associate and instructor at the School of Public Policy and Global Affairs and the assistant director of the Center for Study of Democratic Institutions, CSDI. He has held teaching and research positions in UBC's Political Science Department and Global Reporting Center, and as a postdoctoral fellow at the University of Toronto's Center for Ethics and the Munk School of Global Affairs. Dr. Tanove conducts research in fields of political theory, political communication, and international relations. At CSDI, he oversees research and policy engagement projects on topics including platform governance and democracy. He has published peer-reviewed articles and book chapters on the challenges that digital media pose to democracy and human rights, including in journals such as Political Communication, the International Journal of Press and Politics, and the Political Research Quarterly. Dr. Tanove's policy reports have tackled topics such as social media regulation, artificial intelligence, election security, and responses to online harassment. His reports with CSDI include Harmful Hallucinations, Generative AI and Elections, and Trolled on the Campaign Trail, Online Incivility and Abuse in Canadian Politics. He regularly publishes op-eds and engages news media and previously worked as an award-winning journalist. So with that, I would like to hand over the mic to our first presenter, Dr. Julia Smith.
Thanks so much for the warm welcome. It's a pleasure to be here with you all today. I'm going to start off our discussion talking about moral distress, which is an area of research I've become very interested in since COVID. Next slide, please. So first, let's start with what is moral distress. I believe many of you here are healthcare workers. You probably, or quite possibly, have heard this term before. The concept of moral distress originally developed out of nursing studies and it has since expanded to other healthcare fields, as well as to looking at experiences of teachers and other folks in the caring professions. And it's a term for the distress, the internal distress that occurs when a healthcare provider, in this case, is unable to provide the care that they feel is ethically required due to external or structural constraints. So common examples of moral distress are not being able to provide the care you feel is required of a patient because you're short-staffed and you just don't have enough time. Or in resource constrained settings, not having the medications or materials needed to provide care. The research has shown consistently that these experiences of moral distress are associated with poor mental health amongst healthcare workers. It can lead to ongoing anxiety and depression and other mental health impacts, and also lead to burnout and attrition. So there's a very strong association between high levels of moral distress and folks leaving the healthcare field, which is one of the reasons it's really important to study. To understand what is causing so many of you to experience distress, and then look at how to address it, both to support healthcare worker mental health and wellness, and to support the broader health system wellness and resilience. Next slide. So taking that kind of definition into account, we'd like to just start off a discussion by asking you to go to this Slido and anonymously answer this question. Have you ever experienced moral distress before? I'll just give everyone a few minutes to do that. And I just realized that I don't have capacity to see the results. I don't know if it's possible to actually share the results. Oh, here we go. Perfect. Thank you, Allison. Okay. So we're seeing a really high percentage of folks that have experienced moral distress. Some folks that are unsure. Nobody who has answered no. This doesn't surprise me at all. We know this is a common experience in the healthcare field due to the many challenges of the important work you all do. All right, let's go to next slide, please. So I got really interested in studying and understanding moral distress during COVID. At that time, I was doing research with healthcare workers, so with nurses, doctors, people working in long-term care, people working in community health fields. And I was basically just having very general conversations with them, asking them about the challenges they were facing during those initial years of the pandemic, so 2020, 2021. In those 2 years, I interviewed or held focus groups with over 200 healthcare workers. And during those conversations, I kept hearing about this distress, these really hard experiences of healthcare workers, from healthcare workers. And I was trying to kind of put my finger on how to understand this. And you can see some of the examples here. So the first example is from a nurse who was working in a COVID ward in a relatively small hospital. So she was often the only person on site there. And you can see this really horrendous situation where she was trying to get all the PPE on, and she didn't get it on, or she had to take some extra time to get it on, and the person that she was caring for passed away. And I think, this kind of bolded part of the quote really summarizes this experience of moral distress, of feeling like, she's saying, I know it's not my fault, which implies that she is dealing with self-blame. And she's like, but the system, it makes it difficult. So it's the system, the broader context that's forcing her into these situations. I talked to a lot of people working in long-term care, which was where, of course, we unfortunately had the highest number of COVID deaths. And here you can see a quote from a nurse saying, you know, the experience there every day really stuck with her, really wasn't something she could shake off. She, you know, she was seeing people dying and she was saying, there's nothing I can do about it. So again, that feeling of helplessness and power is also really central to understanding moral distress. Next slide. So following this research during the first few years of COVID, we wanted to understand moral distress experiences a bit further. So we conducted a survey, and I was really interested in looking at who experiences what types of distress. So in the survey, we looked at results by gender, by profession, and by race. You can see one of our graphs here, which is looking at COVID-related moral distress. And you can see, you know, one thing that really came up was patient isolation and high levels of distress here, particularly for women. So seeing patients be isolated because of physical distancing policies was really challenging. You know, death, but patients dying alone. Another one, a topic that came up quite a lot was risk to dependence. So healthcare workers feeling sort of trapped in terms of recognizing their work, but they might increase risk of infection, which they might then bring home to children or elderly relatives and so on. Very concerningly, from a broader perspective, we found 57.7% of participants were considering leaving their employment due to moral distress, and the number was even higher amongst nurses. These findings were very similar to healthcare worker union surveys that were done at the time. I should specify that this is specific to British Columbia. And at the same time, some of the big unions here had done surveys around attrition and burnout, and they found very similar numbers. So this really shows the impact of moral distress and the need to understand it in order to address it. Next slide. So here are some further results from that survey. We looked, because this final survey was conducted in late 2022, early 2023, we also asked about broader experiences of moral distress. And this is a time when, you know, healthcare was getting back to what was considered normal, but there was, you know, high attrition, high demand, and so people were very overworked. We heard a lot about that. We also heard a lot about how racism, discrimination, sexism contributes to moral distress. So you can see in this quote, this nurse who was a racialized person talks about experiencing daily microaggressions and then feeling like she couldn't focus and do her job properly and feeling distressed over that. There was also talk about staffing levels. And I think, you know, this end of this quote really sums up, you know, this experience of moral distress in terms of it feels so disheartening to go home at the end of the day feeling like you could have done more, but you didn't have the time or had to prioritize other work. Next slide. So it's really important to understand moral distress in order to understand how to address it. And this is something that we also included in our survey. So we asked participants what it was their preferred coping strategy with moral distress. And you can see some of those here. And the darker circles are the answers that had the highest number of respondents. So people really, you know, sought out peer support, outdoor activities, family support, taking time off, exercise again, those sort of things. Interestingly, we found coping mechanisms like counseling and support lines were much lower on the list of preferences. Which especially in terms of counseling surprised me. It may be that some of the workers we spoke to did not have sort of benefits for counseling and so did not have access to it. Or it might be that dealing with this type of distress, you know, there's something about things like outdoor activities are really getting away from it that's effective. And we're doing more research to better understand that. Other themes that really came up here was around decision making. There was a lot of qualitative responses that spoke to the need for transparency and communication with those those making decisions and collaboration in terms of problem solving in the health system, and having that sort of like information from frontline workers that meaningfully feeds into decision making. And this comes back to the idea of moral distress being about power and feeling disempowered. And our responses really showed that healthcare workers wanted to be empowered to change the context where they were working for the better. Next slide. Okay, so that's the kind of background of my research on moral distress and why we're doing our future study, which we're going to tell you about in a moment. But first, I want to hand over to Dr. Heidi Torvik, who's going to share results from their research on online abuse and harassment of health communicators. Thank you.
Thank you so much, Dr. Smith. It's a real pleasure to be with you today. And what I'm going to talk about, maybe something that some of you have experienced or people who have. So I also just want to acknowledge that these are tough topics. And if you feel like you need to take a break or do something else for your own mental health, that's obviously very understandable. So what we're going to be talking about in the next 10 minutes is just the research that Dr. Tanove and I have been doing over the last few years, really looking at online abuse and harassment of health communicators. And I'll say that we came to this with also prior experience looking at the online abuse and harassment of other professional groups, whether political candidates or, in the case of Dr. Tanove, also journalists. So we were able to put what was happening to health communicators into this broader context of some things that were similar to other professional groups and then some things that perhaps were different as well. Next slide, please. So I want to first give you a little bit of background because, of course, when we're talking about online abuse, a lot of what we're talking about are things that are happening on social media platforms. And so the ability for online abuse to even happen depends upon the policies of those platforms. What are the sorts of materials that they, in fact, allow on those platforms, whether it's material that they would delete or that they might downrank so it doesn't fully appear. Now, these platform policies have changed quite a lot over the last 5 to 6 years, particularly in the realm of health-related information. So prior to the COVID-19 pandemic, the major platforms like YouTube, Facebook, etc., generally didn't really have specific policies related to health information. The policies weren't clear and they tended to be much more ad hoc in their reactions. So for example, YouTube demonetized vaccine misinformation channels in 2019 after there was a measles outbreak. The real change and transformation in platform policies came with the pandemic in 2020, where all the major platforms created significant new policies related to health and particularly pandemic information and, of course, vaccines in particular. So this included things like promoting authoritative content, providing warning labels, reducing the visibility of problematic information, also removing content or even banning accounts of consistently promoting conspiracy theories or dangerous faux treatments, etc. And this also came with more collaborations, for example, with the World Health Organization and others, as the platforms urgently sought advice from experts on what was actually reliable information and what was not. We have, however, over the last year and a bit, seen the rolling back of many of those policies, particularly in 2025. So as just one example, in early 2025, Meta, the company that owns Facebook, Instagram, WhatsApp, ended its use of fact checkers in the United States. And we've also seen that the efficacy of many policies that do still exist are undermined by the uneven enforcement of those policies on platforms. They've moved ever more towards AI enforcement, which they claim is 88% effective, but there's no transparency, so it's hard for us to really assess as researchers how effective some of the enforcement of policies actually is. Next slide, please. The other thing that we find in our research, which I'll talk about in just a second, is that social media platforms are, of course, important, but there's a much bigger and broader online ecosystem where information is floating around in different ways and potentially problematic information is being promoted. There are also some of these are just broader developments over the last couple of years. So we've seen, particularly over the last few years, what we think of as a fragmentation of the online ecosystem. Yes, there are major platforms, the Facebooks, the Twitter/X, Reddit, etc., but there's an increasing role of other types of platforms, whether more private messaging channels like Telegram or more kind of alternative, further right, generally platforms like Rumble, which is a sort of further right YouTube, or President Donald Trump's Truth Social. So this fragments where people are gathering to talk about information. We also see that, especially in terms of vaccine information, that market platforms like Amazon, which allow self-publishing of books, are actually pretty crucial places where some of this information is being disseminated. And finally, that crowdfunding is actually a really critical part of the ecosystem as well, because there are campaigns that can be placed around sort of any kinds of different activities. So the reason I give you the background on this broader ecosystem is that when we're looking at the abuse of health communicators, we need to understand where it's happening, and that online ecosystem is a major place where abuse of health communicators is happening, and where particularly broader problems of poor information quality intersect with abuse of health communicators who are trying to provide high quality information. Next slide, please. So what we started to do in our research was, particularly beginning in 2021 and 2022, we were both observing and hearing from health communicators that online abuse was dramatically increasing. You can think of various examples, I'm sure anecdotally, that you read over those years of top health communicators receiving death threats or worse, rape threats, or having to leave their houses because they were concerned that these online threats might manifest offline as well. So we were seeing what many people were telling us was an increase in online abuse. And so we started to organize focus groups and conduct interviews, as well as looking at social media material to understand that online abuse, and also to really understand from those who are experiencing it how they might hope we respond. So we identified 4 main reasons why the pandemic had increased online abuse so dramatically. And I'll add that this was happening for other professional groups as well. But in particular for health communicators, most obviously, they were in the spotlight in a way that they had not been before, whether it was daily press conferences or even at more municipal levels, communicating with publics, and much more so than usual. There was also a broader sense of hardship, stress, and social polarization that was often expressing itself through frustration and online abuse against those who seemed to be communicating policies that people were frustrated about. More broadly, just an intense politicization of health policies, where in some cases these became the focus of political campaigns, which meant that even if they weren't themselves, of course, campaigning, health communicators would be at the heart of some political campaigns. And then finally, in many disinformation campaigns, we've seen that disrespect, disparagement, and online abuse are important parts of those kind of campaigns, which focus on what are the top issues of the day. And of course, for some years, the pandemic was the top issue. Next slide, please. So what we did, as I mentioned, you can see here at the bottom of the slide, is we interviewed 35 health communicators working in various different roles across Canada. We did virtual focus groups and workshops, and also questionnaires of those who participated. Now, of course, it's self-selecting in the sense that people had to be interested in the topic in order to participate, but we found that high levels, really 88% of those who respond to our questionnaire had experienced some type of online abuse, with 30% receiving death threats. And we also found what we think of as reputational attacks, with 79% being accused of being unprofessional or unethical in some way. So we tried to break down then what are the different types of online abuse that people are experiencing. And there are four main types that continue in many ways today. And the first were threats of various kinds, sometimes very explicit, but sometimes more ambiguous, threatening people with Nuremberg trials, obviously the trials of Nazi criminals after World War II, threatening the same against health professionals. There was also often hate speech, whether anti-Asian, anti-Semitic, sexist, transphobic, etc. A whole set of conspiracy theories, whether about the sinister origins of COVID or the reasons for restrictions during the pandemic, etc. And then finally, a whole host of accusations of incompetence. So here we really distinguish between a lot of vigorous and rigorous criticism, something we want to see in a democracy, people debating policies, debating approaches, versus things that really veered into really hostile attacks on people's reputation. Next slide, please. Now, it's not just enough, of course, to document this abuse. We also really wanted to understand what the consequences of this were. So our interviews and questionnaires and focus groups try to ask people then what the effects of this online abuse were. And some of this builds then on what Dr. Smith said about moral distress. So we bucketed this into 4 different categories. The first was seeing that people often feared for their personal safety in different ways. And I've described a little bit some of the consequences of that. The second was effects in different ways on psychological health and well-being. Thirdly, we found that people did experience, in some cases, some professional insecurity, where there would be complaints to professional bodies or ethics boards, even lawsuits, people worried about their job security, their further employability, or in the case of health communicators who were more research focused, changing the kinds of topics that they focused on because of their experience of online abuse or their fears of experiencing online abuse in the future. And then, of course, even more broadly, beyond the individuals affected, there are huge societal consequences to this type of online abuse. Curbing the circulation impact of research. People might be doing the research, but they don't necessarily want to communicate about it in the media more publicly because they worry about online abuse. People's willingness to engage in health advocacy in different ways. And finally, that this may be constraining the plurality of voices that we need to talk about health issues within Canadian society. So finally, what we found from our research, which delved more into the different coping strategies that people had, whether more emotion-based or problem-based, we found that in general, people who were targeted were struggling alone, and they were seeking out peer support or family support, but not really institutional support, even though so much of this online abuse was happening because of communicating about what they work on, or in some cases, as part of their actual job. Next slide. So this is where I think this focus on institutional support is something that we are now very, very interested in working on as a next step in trying to really help people deal with online abuse. So we're very curious to hear from you what you think are the greatest gaps in institutional support. And I'll get you to write just 1 to 3 words. I'm sure many of you could write paragraphs, but in the interest of producing a word cloud and get a little bit of a sense from you of where you think that institutions could go to really support people who are experiencing online abuse and harassment. So 1 to 3 words, and then on the Slido, and then we can go to look at the word cloud we've collectively produced. I'll give you another 10 seconds or so, and then I'll let us switch to the Slido slide. Perfect. Okay, thank you so much. Yeah, lack of knowledge, lack of a lot of them dealing with awareness, lack of acknowledgement. Yeah, sometimes understanding, reporting mechanisms. Yes, a lot of people we spoke to talked about stigma and fear, worrying about whether their workplace would actually be able to help in useful ways. Silos is something that we have absolutely encountered in this. So there might be people who can deal with one bit, but not all of it. Pay or funding for this, yes. And then finally, human resources. And in some ways, it's also about where does this in fact sit? So human resources and silos are a little bit similar because there are parts of this human resources can deal with, but many that in most cases, human resources cannot. So yes, thank you. It's very helpful. It's both the institutional, but there's also the emotional aspects for people as well. All right, let's go back to the slides. And then the next slide. Thank you so much. So what we've tried to now start to do, and that's why your response are helpful, because we're really only in our, I would say, middle stages of thinking about this, is what then are the organizational responses that we will be looking for. So we've at the moment got four buckets of training for leadership, administrators, researchers, and of course, communicators themselves. Funding, which was of course brought up on the Slido. So funding for psychological support, but also legal defense and cyber security as well, so that people can be prepared and protect themselves to avoid something like doxing. That in the communication from the organization, there's support, again, a word that came up in the Slido, unambiguous support for academic freedom or other types of freedom and condemnation of harassment. So it's clear that the workplace is standing behind individuals affected by online abuse and harassment. And then finally, super clear processes, having, even if it's as basic as management checklists, decision-making trees, or best practice guides on how to deal with this problem. And then we're also thinking about where bystanders and peers can also help as well. But let's focus, for now on the institutional response. Next slide, please. So what we started to do is to look at this from the university perspective, to try and get a sense of, as someone put it, the silos. What are all the different places that can actually potentially provide help on online abuse and harassment? We've got a policy brief forthcoming, which is started by looking at UBC and universities, but our aim is then to move on to health institutions. So we would very much appreciate thinking this through with all of you, and in particular health workplace settings. So what we're proposing then is you really need what we're calling a wraparound institutional model, where you bring together all of these different silos. So you've got 7 different offices or institutions that can be part of supporting people during online harassment. There'll be a policy brief forthcoming very soon that has this diagram. So if you want to bring this to your workplace, you'll be able to soon. Next slide, please. And so finally, let me then sum up with some takeaways before passing back to Antonella. We're suggesting that people really need to be prepared, I'm afraid, for an increased pollution of the information environment. What's required is not just a reactive strategy, but really proactive strategies, whether it's pre-bunking problematic information, providing clear and high quality information, or also finding ways to prepare for online abuse and harassment, unfortunately. So it's important to anticipate that there are these toxic online information environments that lead to the abuse of health communicators, which requires implementation of institutional support. And our work is really trying to drill down on exactly what that should look like in a health setting in next steps. Thank you so much.
All right. Thank you, Julia, Heidi, and Chris. Well, Chris, I guess we'll be hearing from you shortly, but thank you for these important insights and for sharing your research with us. So prior to jumping into the Q&A session, I understand you folks have launched a new survey. Allison, if you could please move to the next slide. Thank you so much. And this survey is aimed at supporting healthcare workers to navigate moral distress and online harassment, particularly amid the rising vaccine hesitancy that's going on. So Julia and Chris, I was wondering, can you tell me a little bit more about this survey and what you hope to achieve, as well as share some preliminary insights or findings from the survey since it's been active for a couple of months now?
Yeah, for sure. Thanks so much. So you can see the link here to join this survey. We're interested in hearing from healthcare workers in diverse settings, so people working in hospitals, clinics, pharmacies, community settings. We want to hear from you. This survey is about experiences related to immunization and dealing with vaccine hesitancy and harassment related to immunization. But we recognize that these experiences are wide-ranging, so we're not specifically looking for healthcare workers only working in immunization or regularly providing vaccines. Really, anyone who's having conversations or engaging with patients in any capacity that may relate to immunization and vaccines is really welcome to complete the survey. So please, do consider searching out the survey and filling it in, and also share with your colleagues and friends. The questions are about attitudes towards vaccination, moral distress in relation to your role in immunization, and experiences of online and offline harassment. Next slide, please. And just to, kind of emphasize, we're really interested in continuing to gather data on both moral distress and harassment, because we recognize that even though the emergency phase of the COVID pandemic is, over and we're moving in different times now, and the context has changed a lot since the original work we did, there's still a lot of challenges that are being experienced. So we're still hearing about those providing vaccines being harassed, dissuaded from providing vaccines, and discouraged. We're witnessing vaccine preventable illnesses in our communities, our patients, our family members. There is a decline in, routine vaccination rates in Canada, as well as vaccinations for things like influenza and COVID and other infectious diseases. And so, we're seeing things like the measles outbreaks, which healthcare workers, of course, again, are on the front lines of responding to. And we also recognize that this is a context of continued high rates of burnout in the healthcare workforce, that most, if not all, healthcare settings are somewhat understaffed. The healthcare workers are working really, really hard amidst these shortages, and it's a challenging time. And so there's a context of risk of moral distress and burnout unrelated to vaccinations and immunizations, and disease outbreaks, but that is going to really interact with those experiences. And we want to understand that in order to develop strategies with healthcare workers on how to mitigate those harms. Next slide. So as we noted, this survey is already in the field. We're already starting to get results in, and it's been really interesting to see them. There's most of the questions are, quantitative, like multiple choice and click through, so it shouldn't take you too long to fill it out. There is space for qualitative responses, and we've actually been getting a lot of qualitative responses, which is often unusual in surveys, but we're really grateful for it because there's some very interesting findings and insights here. You can see this quote from a healthcare worker where they say, "For many healthcare professionals, the impacts of moral distress were felt because of lack of support by government officials, the loud voices of anti-vaxxers being amplified by mainstream media, social media, and the constant public protests against vaccination. Improved education campaigns in schools and among parents are critical." So this is, a great quote that really shows the context that healthcare workers are dealing in, the need for government support, and then also make some really concrete suggestions. So these are the types of insights we're so grateful to have. And I really, again, encourage you to fill in the survey and share with your colleagues. I'll pass on now to Chris. I think he's going to speak a little bit about some of the other results from the survey.
Yes, thank you very much, Julia, and great to be speaking with everyone. I just wanted to briefly, before we get to questions, point out that this isn't a problem that the health sector is alone in facing. Other public-facing professions have been facing these increasing levels of online and in-person harassment over recent years. And as Heidi mentioned, I've been doing research on journalists and work with journalists to address this issue recently. And I wanted to mention that because I think the journalism sector in Canada has done a little better than the health sector on responding to these issues. Again, during the kind of early pandemic days, there was a lot of attention to the issue, and a number of the large news outlets and unions and such took a couple actions. They fielded a big comprehensive survey, which allowed them to better understand the prevalence of online and in-person abuse and identify types of individuals who are particularly affected by it. So for example, they found here, you can see that 1 in 3 journalists were facing online harassment at least monthly, that some types of journalists are working on certain beats were facing more frequent online harassment, as were individuals who were younger journalists, LGBTQ plus journalists, and some other identity groups were facing either higher or specific types of problematic communication and abuse. Beyond the research and building on it, the CBC and news outlets and media unions improved their policies and started to make some more resources available to address the issue. One of the things that they identified was that freelance journalists or those working for smaller news outlets were kind of particularly unsupported. And so the Canadian Association of Journalists created a peer network and an emergency support fund, particularly for those who weren't getting support through their employer. So I think that shows us some elements of a good sectoral response. Of course, there's a lot still to be done to improve the situation for journalists in Canada. Turning back to healthcare providers, I think, our survey, we hope, can help us identify gaps in support, particularly for types of individuals that maybe aren't getting as much support or facing particularly challenging types of online and in-person abuse. And one thing that stuck out to me and to others from some of the early responses was the experience of people in small or rural communities who some describe themselves as being the face for vaccinations for a whole community and therefore being targeted by those who are resistant to vaccination. And so we have this comment here at the end, and I'm not going to read the whole thing, but this is just the gist of someone talking about how they've had to create this distance between themselves and friends and family, in part because of what they saw circulating online about vaccination and related public health policies. So there's a lot we can learn to identify how to be really concrete and effective in promoting policy responses to support healthcare providers. So again, we would really appreciate it if you can do the survey or share it with your colleagues. And then now I think we're ready for some questions.
All right, fantastic. Thanks again for sharing your insights on this survey and as well on online harassment. As a reminder to folks in the audience, please feel free to scan the QR code as well as click on the link in the chat to access the survey if you wish to participate. We would love to hear from you. So now I think we can move on to our Q&A session. Yeah, I think with that, I know there's a couple of questions in the chat, but just before I get into them, just while we're on the topic of dealing with online harassment on social media, Chris, I was wondering, and this is actually a question that was submitted in our pre-registration survey questions, but do you have any tips on how to respond, limit, and/or block online comments, specifically health-related ones, on vaccine promotion? And do you also have any mitigation strategies for immunizers who target online harassment? I know it's kind of a double question, but yeah, love to hear more.
Yeah, I mean, I think, so for starters, there's no one-size-fits-all easy answer to this, because it partly depends on where someone is facing hostile or abusive communication, what one's role is, and people's also individual comfort levels with contentious or contentious conversations. So some of the folks we've spoken to have tried to respond in public threads on social media, for instance, to directly counteract false claims or misleading claims. So they're addressing this publicly. Some folks try to shift the conversation to direct messages with an individual who's either making an uncivil remark or a misleading claim, to try and make it more of a human conversation about things. But by and large, it's generally more effective and easier not to get into that back and forth within threads and those sorts of things, but to clearly and publicly post the information you want people to have access to, maybe addressing some of the misperceptions or concerns that people were expressing in comments, but to be able to control your message and be as clear as possible about it. And I should add, a lot of the online abuse does come not in public social media posts, but in email, to your institutional email or to direct messages and such. Yeah, we have a lot of recommendations for different steps people can take and organizations can take. So it's already in the chat there, but we have put forward an approach and resources for those at the University of British Columbia who are facing online abuse and in-person abuse. And I'd encourage people to go there and look at the bottom of it, because we also have other resources that we link to if people want to see a range of steps they could take.
Fantastic. Thanks so much for sharing. And I will be sharing these resources that Rakib has been putting in the chat when we share out the recording. So we have a lot of different resources for you folks. But thanks so much, Chris. I think moving on to some of the questions in the chat. I see there's a question that's been, I believe, upvoted. Thank you for your presentation. As pharmacists are taking on more immunization roles, does your research include studying those healthcare workers and environments? I don't know who wants to tackle that question on pharmacists in the research field. In that field.
I can tackle that. I mean, the short answer is yes, it does include pharmacists, and pharmacists are included in the survey. The survey that we have out now does include pharmacists in the kind of recruitment strategy. So if you're a pharmacist or you know pharmacists, please share it. I also want to note that we actually are about to launch a national study specifically on the role of pharmacy staff in informed decision-making on vaccination. And we're really interested in better understanding their experiences as this, they fill this really important role in community in terms of health communication and connecting with folks. So that study is about to be launched by one of our fabulous PhD students, Zoe Hong, and Professor Kelly Lee.
All right, fantastic. Thanks so much, Julia. So the next question in the chat is, provided the coping of oneself was exacerbated during pandemic measures, including confinement, how would we bring about a different behavior during the next pandemic?
I think I can answer that one too, just based on the research around COVID and moral distress. And it's such a good question, right? Like the coping strategies like peer support and getting together with family all became very difficult when we were also trying to prevent the spread of the virus. However, I think what we did learn during the pandemic was how important interactions are and the need to prioritize those and find ways to do it safely. In my research with healthcare workers during COVID, I heard over and over again about the importance of both formal and informal peer support. And so I think that's really something that needs to be, emphasized and built into pandemic preparedness and response as a way to continue to support healthcare workers.
All right, thanks so much, Julia. All right, actually, another question, a couple of other questions have popped up. So is it possible to promote the depoliticization of public health measures across the political spectrum, federal versus provincial, as even mainstream parties use COVID to score political points? Very interesting question. I don't know if anybody is able to tackle that one on the depoliticization of public health.
I can take that one quickly. I need to say, I'm also a trained historian, and we see these moments where health, particularly during pandemics, does become politicized. And this makes sense, right? In the sense that if a political campaign is happening during a pandemic, this is a key issue that people want to be addressed. But then there's the sort of question of how in different countries it didn't become a political football, so to speak. So I think that's one thing to say, is that there's within a democracy, a reasonable debate you're going to have if an election is happening during a moment where healthcare is a priority topic. We did, though, see in other places that there were different approaches to the role that healthcare communicators were taking, where they didn't necessarily talk about things that were seen as political. So that's one way to think about it, is that there are different models of what you ask chief public health officers or other health communicators to do. Do they just communicate about health measures, or do they also communicate in how people might be feeling, acting, etc.? And so there were other places where politicians took more of a front role in communicating what were ultimately more political decisions. So I think that's one way that we can think about this. And there are, in some work that I did all the way back in fall of 2020, I give some examples from places like South Korea or Taiwan, where there's in South Korea, very contentious politics, but very broad agreement actually on COVID measures. So that's some examples of how you might have a very contested political sphere, but you could still build a lot of consensus around health.
Okay, thank you so much, Heidi. Moving on to the question more related to institutional support around moral distress and online harassment. But this person is asking, so when you talk about institutional measures, what role do you feel the government has in protecting its healthcare workers? Are there any policies or strategies you have seen that have been effective in other jurisdictions?
I just might make a couple quick remarks on that. I do think that addressing these issues is part of just expanding and improving on broader occupational health and safety regulations. And government can be certainly a leading policymaker there to set standards and clarify best practices and such. And in terms of other jurisdictions that have worked on it, I mean, one interesting thing we've seen is looking, this isn't so much other jurisdictions, but we have another set of research that's looking at the professional bodies by physicians in Canada and their efforts to promote or their neglect of this topic. And so one part of that has been about encouraging safe and civil use of social media as health professionals. So health communicators, health professionals are not part of the problem of kind of fomenting more hostility and abuse. And then other parts are kind of setting a benchmark for and encouraging employers to be able to provide appropriate supports and policies. And so, the Canadian Medical Association has some helpful resources and has been useful in some ways at really bringing attention to some of these topics. So there's something that can be learned from them and some other organizations.
Fantastic. Thanks for sharing. All right, another question just popped in. So thank you for your presentation and for your work in this field. I have a question. Our healthcare system faces numerous challenges that can lead to moral injury, one of the factors contributing to the departure of frontline professionals. Have you seen examples of interventions from other countries that have reduced the impact of moral injury, in turn helped decrease attrition?
I suspect that's more of a question for Julia, who unfortunately had to drop off a few minutes early, but I guess maybe I'll take an even bigger step back, which is to say that I think these are exactly the kind of questions that we're trying to ask, and they are the right one, that there are other places around the world that can give us very useful insights, even in broadening also our imagination of what can be done. I know that Julia is doing broader work on this, and there are other colleagues who are looking at global examples and then thinking through that second step of how does this actually apply to Canada as well, because that's obviously, it's easy to look somewhere else, but then really figuring out how do you fit that into the Canadian model is the second important step.
Yeah, and I just had one comment. A few things that are that the folks that we have done focus groups with and interviews, a few have made a remark that really struck me, which is just that they wish there was a clear public acknowledgement of a recognition of some of the things that they are facing, that they do sometimes feel dehumanized. So there are all the important institutional policies to address this, but I think we need to keep having those public conversations where we remind broader publics about just what the experiences are and the need to really kind of humanize and be empathetic to frontline workers.
All right, awesome. Well, I would like to thank you both, Chris, Heidi, and Julia, who has hopped off just a little bit earlier. But thank you all for your presentations. They were very insightful. So with that, maybe, yes, Allison, thanks for bringing up the final slide. So with that, we hope you found this information very valuable to your work. And before you leave, please take a moment to fill out the post-evaluation survey. I'll also put it in the chat right now, as your feedback is important for the future planning of our webinars. So thank you all for joining us, and have a great rest of your day.